I'm the liaison for this committee, and you see the names listed here, and I think the picture speaks a little bit for the committee, which has been very active, very dynamic, very, let's say, not
enthusiastic.
Very enthusiastic and not worrying to take all controversies at face value and taking nothing for granted. And here they're all dressed up with Roman hats. So the first thing they came up with was this statement: functional bowel disorder is a spectrum of GI disorders presenting mainly with the following symptoms, and these are the usual symptoms: abdominal pain, bloating, distension, bowel habit abnormalities. So the word spectrum here, I think, is a kind of deviation in what was at least clearly stated in some of the previous Rome iterations of functional bowel disorders. And then the proposal is currently to divide the functional bowel disorders into 4 distinct categories, and this is fairly close to home the way you see it. The IBS is in there, functional constipation is in there, functional diarrhea is in there, and then functional abdominal bloating and distension. This is a slight variation on what was prior functional abdominal bloating. The novelty is that this decision, which category the patient is in, will be driven by the predominant. So, and here explained as most bothersome symptoms. So this is taking into account that many patients have overlapping symptoms or symptoms that may belong in one or more of these boxes. And in exceptional cases, they say when there is no predominant symptom identifiable, perhaps there might still be room for an unspecified functional bowel disorder category, but this has not been elaborated further. The idea of a continuous spectrum is further shown in this conceptual graph that showed up in the committee's discussions very early on. And I think it's a good way of thinking because it looks at a kind of continuum. On the left you have the severity of constipation from absent to very severe, and on the right the opposite arrow here, the descending arrow, shows the diarrhea with it. And with this is a continuous spectrum of pain, and superimposed on that is the severity of bloating and or distension. And it shows a couple of ideal patients who have only, for instance, functional constipation. So this is a patient where the constipation spectrum of the functional bowel symptom complex is very prominent and very severe, and pain is virtually absent. Here you have the IBS patient in whom pain is very important and who may have a varying stool pattern from constipation to diarrhea or mixed. But the bulk of the patients is in between here, in between extreme functional constipation and extreme IBS, for instance, with constipation, because there is some pain and this is a moving spectrum. And you can make the same moving spectrum for the diarrhea aspect of it. And it also indicates that in most of the patients who have functional constipation, it is very likely functional constipation symptoms to have some coexisting bloating or distension, and the same is true for the IBS consortium spectrum of the functional bowel disorders. And it's kind of rosette here to show that there is potentially a lot of mixture and overlap in patients who have both IBS and functional constipation and functional abdominal bloating distension coexisting. So that is kind of the conceptual background. And also they acknowledge that perhaps where you are in the spectrum, and you may have patients who are very well in one extreme, like having really IBS with constipation, so a lot of pain and constipation, that may not be cast in stone over time and may be susceptible to clinical interventions like therapy. For instance, patients may spontaneously move from functional constipation to IBS if their pain spectrum increases over time. But I think the more interesting one, and perhaps helpful to clinicians, but also if you conceptualize therapeutic or pathophysiological studies, if you bring in an effective therapy in somebody with an IBS with constipation, and you bring in a therapy that relieves the constipation, but does not touch the IBS. This becomes somebody with IBS now, which could be really presenting mainly with pain, and perhaps the constipation part is gone. Or if you improve the pain in somebody with IBS with constipation, but you don't address the constipation, in a way this has become a chronic constipation patient now, which is good relief, with good relief from pain from some type of intervention. So you see, there's been a lot of thought and concepts gone into, and this is just a little bit of the conceptual things that this committee used. Now, functional abdominal bloating and distension, these are considered altogether now as a single entity, functional abdominal bloating and distension, but emphasizing that although bloating and distension frequently coincide, they may exist independently. And so the bloating is the sensation, the subjective sensation of abdominal inflation or flatulence, also called in some language areas, without objective increase of girth, whereas functional abdominal distension is the measurable, therefore potentially made objective also increase in abdominal girth. And it is stated that the pathophysiology and perhaps the management might be different. The bloating may have a hypersensitivity component to it. The distension may actually have some neuromuscular components or some fermentation and gas generation factors to it. They actually propose, and some of the criteria I'm showing are close to the clinical practice, but that there are slightly differences in the diagnostic criteria for epidemiological studies for the clinical practice part and for the clinical trials. And severity thresholds and categorization of need for purity within a spectrum may be higher as you move into clinical practice. Changes from Rome 3, so at this point functional bowel disorders are conceptualized as a spectrum and not necessarily isolated and existing next to one another entities. In some cases, and this is especially in the clinical arena and clinical reality, the overlap might be important and distinction might not be easy. Abdominal bloating is considered a single symptom and not part of discomfort, and actually the term discomfort has been dropped and proposed to be dropped from the definitions because of its vague nature. And switching from one functional bowel disorder category to another, or moving from one predominant symptom to another, may occur as a result of natural history, response to therapy, or both. Bloating and distension are considered together, but indicating that they not necessarily appear together all the time and may have different pathophysiological origins. And what is the predominant symptom or most bothersome symptom becomes very important in the categorization. This is the working definition for IBS. IBS is a functional bowel disorder, and this is coming back in many of their definitions, so just putting in subtext the absence of structural metabolic abnormalities, the onset and the time requirements. So IBS is a functional bowel disorder in which abdominal pain and or bothersome abdominal bloating distension are associated with defecation or a change in bowel habit. And disordered bowel habit is frequently present, constipation, diarrhea, or mix of constipation and diarrhea. So this becomes a slightly more elaborate definition, and some things are different. Changes from Rome 3, discomfort has been deleted from the definition, bloating distension has been included, a consideration that you may have more than 5 clinical subtypes, but whether all of these make it into the criteria is not finalized, and the subtypes based on Bristol stool form scales and whether the thresholds in terms of percentage may be different is still under review. For clinical trials, subtyping based on 2 weeks of diary run-in is recommended, and it's now recognized that sometimes a given patient may share criteria for different subtypes, and it's difficult to establish if they belong into a single one. It is also suggested to establish IBS diagnosis according to a number of steps: clinical history, physical exam, and some minimal laboratory test and colonoscopy in selected patients when needed, and perhaps in some cases therapeutic tests may be used. Functional constipation is a functional bowel disorder in which difficult infrequent or seemingly incomplete defecation predominate, and this does not meet IBS criteria. Pain and or bloating may be present but are not predominant. And moreover, although some patients with constipation also may have pain, in contrast to IBS-C, it is not that clearly associated with the defecation. That is the working proposal. Also here, clinical history, physical exam, so criteria, and then perhaps some additional testing. And there is a harmonization needed and ongoing with the functional anorectal disorders on how to handle dysenergic defecation and how to distinguish it in the chronic constipation group. Is a questionnaire helpful, and how truly is the value of the rectal exam, perhaps in less experienced and less specialized hands. Functional diarrhea, functional bowel disorder characterized by persistent or recurrent passage of loose or watery stools without predominant abdominal pain or bothersome bloating. Some of the same iterations there, so the stepwise diagnostic approach. And then functional abdominal bloating distension is a functional bowel disorder in which a sensation of persistent abdominal inflation, flatulence, and or measurable increase in abdominal girth clearly predominate over other symptoms. Mild pain related to bloating distension may be present as well as minor bowel movement abnormalities. So this is what the Functional Bowel Committee is currently contemplating. This is very much a work in progress. The focus of what I have shown is what I got from them, and is a little bit on the clinical approach and the clinical usage of the criteria. For some of the clinical trial applications, criteria may be more stringent and more strict. But this is a work in progress, and for epidemiology, some of the criteria may be less strict.